presenting today comes out of my master's dissertation in the Department of Geography at the London School of Economics. So my work focuses on the crowding out of public health facilities by private facilities, specifically in post-earthquake Haiti. First, I'm going to provide some context about how I came to this question. Then I'll explain my research design, the methods I use, and then I'll discuss my results. And I'm looking forward to everyone's feedback. All right, I'm sure many people are aware that in the aftermath of the earthquake, there was a large influx of NGOs into Haiti with the purpose of providing, ostensibly with the purpose of providing emergency medical relief, which was much needed after the earthquake. I am interested, however, in the longer-term effects of that influx. Everyone's heard this term bandied about many times now, Haiti, a republic of NGOs, sort of been beating people over the head, but what does that actually mean? So after India, Haiti has the highest number of NGOs per capita, so per person in the world. Something between, the estimates range, 3,000 to 10,000 NGOs. And essentially, when people say Republic of NGOs, they're referring to this shadow, parallel NGO state that's calcified over the decades and has had lasting effects on state-owned public goods infrastructure. So why should we care? You know, if the job is getting done, it doesn't really matter who does it, right? Maybe. However, if you look at the health indicators for Haiti, they're some of the worst health indicators in the region. Just to give a few examples, infant mortality in Haiti is twice what it is in the DR, which shares the island with Haiti, and is nearly 10 times what it is in the US. Infectious disease rates are really high. There's a higher incidence of TB than in any other Latin Caribbean country. Life expectancy is about 12 years lower than the average for the region. And access to care is extremely limited. In addition to that, there have been some negative trends in Haitian health in the recent past. For example, in the early 2000s, maternal mortality actually rose. And then we have the ongoing cholera crisis. Cholera was introduced to Haiti after the earthquake by UN peacekeeping troops, and there have been 500,000 cases approximately, and the epidemic has claimed, I think the newest number is around 6,000 lives. So as a contrast, this isn't up in the slides, one might think of, we're talking about ownership here of facilities. In Cuba, there's sort of the state-owned public goods infrastructure and a universal public healthcare system, and Cuba has some of the best health indicators for the region. So that's sort of the context that led me to this question about private versus public ownership. And the next thing was, okay, how do I approach this in terms of research design? First of all, what is this framework I'm using of crowding out? Well, I'm borrowing the term crowding out from economics, where it's traditionally used to refer to reductions in private investment due to increased government spending in a particular sector. For example, if the government increases social services spending, you see reductions in private charity donations. This is what a traditional sort of economics analysis would refer to as crowding out. Given Haiti's context, however, I chose to invert this paradigm, and I asked instead, how do increases in the number of private actors affect and atrophy, basically, government involvement? I'm especially interested in how the earthquake has affected those patterns. I don't know how many of you are familiar with the work of Naomi Klein, but she has this book called The Shock Doctrine, which is about the way a disaster situation can become a neoliberalizing, profit-making moment, a privatization moment. So that's sort of what I wanted to look at. Now, the data that I used in my project came from collaborative aid efforts after the earthquake. The Pan American Health Organization worked in conjunction with the Haitian Ministry of Public Health and other aid agencies, and they put out a geocoded list of all known health facilities in Haiti. Geocoded means that the data set includes the locational information for the facility so that I, as a geographer, can upload this data onto a geographical information system and then manipulate it, analyze it. I added to my data set geocoded census data from 2003 and other sort of geospatial data like road networks, river networks, fault line networks. That data was also available. All the maps in this presentation are maps I produced through my analysis. And so all this information is sort of made publicly available to facilitate aid efforts, but I also think it can serve as a great resource for social scientists interested in understanding macro patterns in health in Haiti. So that's sort of the data that I use. But going back to the idea of crowding out and changing patterns of ownership, I would say the traditional social science approach for countries that have large data sets would be to use time series data. How have trends changed over time? So theoretically in Haiti, you would look at the years preceding the quake and then after and ask what the differences are. We don't have that data here. As a geographer, however, I can manipulate spatial differences to work around the lack of time series data to try and get an answer to my question. So the earthquake was an event in both space and time, right? And it left spatial and temporal marks on the country. So what I chose to do is I focused on facilities located in IDP camps, which are the camps, specifically the post-earthquake internally displaced person camps, and cholera treatment facilities. In my project, they serve as post-earthquake signifiers. I ask, what are the changes in ownership patterns when I compare sort of the rest of the facilities to these facilities? And I ask if those changes are statistically significant. So what I've done is, I'll just show you these maps here are the distribution of IDP facilities per person per communal section. That's sort of my unit of analysis is the communal section. And on the right, you have cholera treatment facilities. You can see sort of how they're distributed in the country. All right, so essentially I developed a spatial regression analysis to test the strength of post-earthquake signifiers as predictors of increases in the private-public ratio. So for me, increases in this ratio serve as evidence of crowding out. And I'll talk about the two different forms of crowding out in a second, but basically I have a model. My dependent variable is the private-public ratio, facility ratio, and then my independent variables of interest were the IDP presence and proportion, and the proportion of cholera treatment facilities. I also controlled for other variables in my analysis. So I created socioeconomic indicators, I used population density, and geospatial data. And then I asked, okay, when I control for all those things, how much of an effect do these post-earthquake signifiers have? I was looking for two specific forms of crowding out. The first is I chose to call indeterminate crowding out. What this means is simply increases in the private-public ratio. The second kind of crowding out I call absolute crowding out. And this is a little bit more, I place a restriction. Basically, I want to know if each additional private facility means the loss of one public facility. It's called the extreme neutrality principle. So the first form of crowding out, you could hypothesize that the government could invest later in healthcare. So it's not a rigid crowding out. I chose to still include this in my analysis because if you think of any given individual going to a healthcare facility, as this ratio increases, the likelihood of them ending up at a private facility also increases. And here I just have a pie chart that breaks down globally in Haiti ownership information for the healthcare facilities. Okay, so what came out of this analysis? The two plots here, one is for IDP, the effect of IDP facilities, and one is for the cholera facilities. And in both, I've sort of plotted what are called the model residuals, meaning I've taken into account all the other possible explanations, population density, socioeconomic, etc., and have asked, is there still an effect? And as you can see, there is a positive effect. And then I'm asking, all right, is it significant? How significant is it, etc. The takeaways here, IDP facilities had the strongest positive effect on the ownership ratio. I observed both indeterminate and absolute crowding out, and the effect was significant at the 5% level. Interestingly, for cholera facilities, in the country as a whole, I did not observe crowding out. However, when I restricted my analysis to sections containing IDP facilities, there was a very strong, positive, and significant at the 10% level effect of crowding out. And the way I've come to understand this is I realized that there's a post-earthquake region, the part of Haiti that continues to sort of deal with the aftermath of the earthquake, which is where these IDP camps are. And in that region, crowding out is observed, absolute and indeterminate. Okay, how important is that? Well, it turns out that the post-earthquake region, which is also the general region of Port-au-Prince and Port-au-Prince County, has a third of all health facilities in Haiti. A third of all the health facilities in Haiti are located there. Therefore, this is actually a pretty important phenomenon. What are the implications? Some might even argue, well, sometimes the NGOs have the interests of the people sort of more so than the government. Well, it turns out in some of the literature on specifically health and ownership in economics have shown that actually nonprofits in health do not exhibit more altruistic behavior than profit-maximizing firms. And health outcomes for the indigent do not improve when patients are shifted from public to private. And so that was just comparing, like, okay, is there a difference? Do nonprofits, do they act more altruistically? And this study, which was done in 2000, pretty much ruled that out. So ultimately, we need to deal with this question of state capacity being further weakened in the immediate aftermath of the earthquake, possibly for the long term. And how do we reconcile that with the goal of universal public health access, which is desperately needed? And then I have just my map here of the facilities in Port-au-Prince, and yeah, I can't see it very well, so anyway. All right, this research is preliminary. There are a lot of data quality issues, so I've just laid out some steps that could be taken to improve it, and ideas that I had, and I'm looking forward to hearing your feedback. First of all, the facility list, which was wonderful, still has a lot of holes. There's a need for further data collection to determine the ownership status, the operational status, especially after the earthquake, staffing levels, capacities, what kind of services are available in every facility. They've been identified, it's just a matter of getting the rest of this information. Socioeconomic and demographic information for Haiti also needed. The 2003 geocoded census did not contain a household income indicator at all. So that kind of information is severely needed. What would also be helpful is longitudinal patient health outcome surveys, a random sample that tries to get a sense for the country as a whole, and health-seeking practices of individuals. With all this information, one could, develop a really fancy, sophisticated, multi-level model, take everything into account, and you can get a sort of better understanding. But sometimes even just the simpler analyses will point out a phenomenon that is actually occurring. So I think I'll just end there. That's sort of where my research is at, and I look forward to your comments. Thank you.